Okay, so dear participants, we are having our next faculty to come in and to join. It is Dr. Priyanka MK, who is the consultant emergency medicine of Manipal Hospitals, HAL Airport Road, Bangalore. Madam is also an NABH internal assessor and a QI assessor also. She is also faculty and guide for DNB emergency medicine program at Manipal Hospitals, ATLS instructor, ACLS instructor, and so on. Over to you, madam. Thank you so much. And you're 20 minutes from now.
Thank you so much for this. Dr. Saravanan, Kaho, Srinath sir, let me just start sharing my slide. So I'll be talking to you about key performance indicators which are relevant for the Indian emergency departments. I'd like to start with a very rightly said quote by Henry Ford saying quality means do it right when no one is really looking at you. So by key performance indicator, you're saying that it's basically a type of performance assessment that helps you understand how your department is doing. It measures the performance, it's quantitative, and it's really very important for you. So, yeah. So I cannot start talking about KPIs without giving due credence to Don Obedien's model, which was put out in 2005. Where he proposed three-component approach for evaluating the quality of care for any measurement for improvement. So the three components are structure, process, and outcome. And measurement for improvement has an additional component, which is balancing measures. So Don Obedien believed that structure measures do have an impact on process measures, and these definitely have an impact on outcome measures. And I think what he said in 2005 will hold good today and even the years to come forth. So when we apply his model to healthcare, especially the emergency department, when you're talking about structure, you're talking about physical and organizational characteristics in your emergency department. And process involves focus onto where the care is delivered to the patients, that is services, diagnostics, and treatments. And outcomes are basically effect of the emergency services on the status of the patients and the populations. So any key performance indicator has to be SMART. When I say SMART, it has to be specific, measurable, achievable, relevant, and time-bound. So what do I mean by each of this? When I say specific, it should be clearly defined and focus on a specific objective or goal. It should provide a clear picture of what is being measured, how it will be measured, and why it is important to be measured. And when you start measuring it, it should be quantifiable. It should be measurable. You should be able to use clear and concise metrics. You should be able to provide an accurate representation of the current state of performance, but you should also allow for comparison over time. What you're trying to measure today, you should be able to measure maybe a year later, 5 years later, and you should set benchmarks for that. I'll come to that in some time. The third thing is it should be achievable and realistic. So when I say achievable and realistic, you should base it on resources available and the current state of performance. And you should also provide a challenging but achievable goal. So you should be able to motivate your team to go towards it. It should be relevant. It should be directly related to the services provided by the emergency department. There are a lot of key performance indicators which the hospital acquires. Not many are really relevant to the emergency department. So you should see which is really relevant to you and use those. It should be time-bound. You should be able to give a specific timeline or a deadline associated with it, and this should provide a clear target for assessment. Benchmarking. Benchmarking of a performance indicator is extremely important. When I say benchmarking, it means it is something which is serving as a standard. There should be something which you're trying to reach out to, some goal. And the others should know that they're being measured or judged based on that goal. But when it comes to setting a performance indicator, not every performance indicator you will be able to benchmark at 100%. And you should understand that not always will an ED be able to perform at its maximum efficiency level. So you should give weightage even for that. And also, if you develop a wrong KPI, you're going to just stress out your whole team and it'll cause more harm than help. So let us start looking at how structure parameters can help you develop your key performance indicators for the emergency department. The physical infrastructure of the department plays a very, very important role in developing any performance indicator. And when I say physical infrastructure, I'm talking about space, adequate number of treatment rooms, your A, B, C zones, priority bays, triage areas, waiting areas, clear and easy access for ambulances and patients, including disability access, presence of safety equipment, fire alarms, sprinklers, emergency exits, available of modern diagnostic and therapeutic equipment, stat labs, point of care, ultrasound machine, standby X-ray machine, cleanliness and maintenance of the facility as well. The staffing also comes under infrastructure. So you're looking at staffing levels and staffing ratios. Number of doctor to patient ratio, number of nurse to patient ratio, nurse patient ratio in zone A, nurse patient ratio in the green zone, the qualifications of the staff, their training levels, have they all been trained in cardiac life support, pediatric life support, and basic life support? If you have an ultrasound machine, they should be trained in that as well. Experience of the staff, then staff health, the sickness of the staff, the post-exposure prophylaxis of the staff, the stress handling of the staff. The third under structure comes under operational capacity. That is, you're looking at the efficiency and accuracy of the triage processes, including availability of a standardized triage in a system, the emergency severity index, in other words. Also, electronic health records and emergency preparedness. That is there a disaster management plan? The mass casualty incidents, pandemics, are you running drills for this? Mock drills and monitoring of the mock drills and taking adequate action for lacunae in the mock drills are very, very important. Resource availability, medications. So ED is not really a place where you set out prescriptions and people go buying. So availability of the medications, inadequate stock, essential medications, high-risk medications, LASA, CAPA, blood products, the TAT for blood, and the medical supplies are also really very important. Point of care, like what I said, and support services. Ancillary services are extremely important. People to help you with registration, housekeeping staff to help you with movement of the patient, and referrals from other departments or doctors. Availability of bed, number of beds available in the emergency department relative to the patient load, presence or availability of the dedicated observation unit for short-term patient monitoring. What is the turnaround time for patient? How long is the patient remaining in the observation unit? What is the deterioration rate or the improvement rate? Are there any discharges from the observation unit? And admission and discharge efficiencies. When we look at process indicators, we start with timings. Triage time, that is the patient arrival time to the initial triage assessment. Why is this really important? Because short triage times are essential for quickly identifying and treating critically ill patient. The second is door-to-doctor time, which is quite different from door-to-initial assessment documentation time. So door-to-doctor time would be the time from patient's first arrival to first contact with the physician. And shorter door-to-doctor times reduce delays in cares and thereby improve patient outcomes. Door-to-initial assessment documentation time is more of how long it would take for you to complete your initial assessment from when the patient arrives. Length of stay is defined as the total time a patient spends in the ED starting from arrival to the ED. And shorter length of stays are indicative of efficient processes and generally reduces overcrowding. It's also very important to have performance indicators related to clinical processes. Time to pain management. Time to pain management would be from the time the patient came with a complaint of pain, with measurement of the severity of the pain, to administration of the pain medication, whether it's IV, oral, topical, whatever it may be. That would be the time to pain management. Time to diagnostic evaluation. ECG in STEMI is a key performance indicator. CT scan or first imaging in acute ischemic acute strokes is another very important key performance indicator. Treatment-related timings. Time from diagnosis to time to start of definitive treatment in the form of IV thrombolysis in acute strokes, antibiotics and septic shock, time to anti-epileptic medication in a patient with seizure and trauma. And delays in treatment, delays in diagnostic can also cause worsening of outcomes. The other important parameter in relation to processes would be errors. Prescription errors, medication errors, transcription errors, lab errors, reporting errors. All these you can't really set benchmarks for all these, but identifying these indicators and reporting them, monitoring them is very, very important. Effectiveness of processes, effectiveness of services. Were there any falls? Patient who fell from the trolley. That means there's a problem with the structure, either the trolley or the process. The handle of the gurney was not put up. So that again reflects on the effectiveness. Patients who left without being seen, satisfaction indices, crowding indicators, and equipment downtime. High crowding indicators are often associated with lower quality of care and increased risk of adverse events. When we look at disposition from the ED, the patients can either be admitted to an inpatient facility or referred out to another hospital or discharged to home. So when you look at admission rate from ED, you look at deterioration in the ward, how many were wrongly assessed and deteriorated in the ward can also be a performance indicator for the ED. Discharge instruction compliance, percentage of patients who receive and understand the discharge instructions and actually comply to it. Revisit rate. Usually the time frame set for ED revisits is 72 hours. So the percentage of patients who return to the ED within a specific time frame. When you look at revisit rate, there's a difference between revisit and follow-up. It's an unplanned revisit and not a follow-up. A person who's being called back, a fever patient who's being called back to do a repeat blood count, wouldn't really actually be a revisit because it's a planned follow-up. We can also have performance indicators related to outcome. So procedure-related outcomes, a lot of procedures being done in the emergency department. So you have central lines, you can look at their bloodstream infections, you can look at ventilator-associated pneumonia outcomes for intubated patients and catheter-associated UTI. Mortality rates, maternal mortality, mortality in the ER, mortality in the ward within 24 hours of admission, infant mortality, perinatal, and adult mortality. CPR effectiveness is another parameter which can give you a very, very high reflection of your mortality rate. Patient-related would be the incidence of adverse events, the incidence of unplanned ICU admissions. Patient being in the ER or in the observation unit gets moved to the ICU, which is not really planned, an otherwise stable patient. Will also be a very good performance indicator. Patient satisfaction scores. There are a lot of survey scores and patient-reported outcomes which can be monitored. Follow-up compliance status and post-ED functional status, that is, you're looking at the physical and mental functioning of the patient, can also be a good assessment. Surveillance activities. So when we look at surveillance activities, we're looking at infection control, that is healthcare-associated infections, and implementation and monitoring of these infection control protocols to control the spread of diseases. Ensuring compliance with established clinical guidelines, protocols, legal regulations, and it's very important to regularly audit this to verify adherence to standards of care. Comparing performance metrics with national or regional benchmarks to identify improvement and also to participate in quality improvement collaboratives or registries. And it's very important to use CQI programs and especially using this surveillance data to drive ongoing improvements in ED processes and patient outcomes. So I would like to summarize saying you have to decide what you want to measure. Collect the data. Data collection is very important. You need to know what to collect, how to collect, who has to collect the data, and how you're going to represent the data. Then it's very important to analyze the data which is collected, report the results. Once you report the results, you should be able to take action according to the results which have been reported, and you should be able to repeat this on a regular basis. And then when you have adequate data that you have collected, you can analyze it over years and see what has changed, and that will really reflect on the performance of the ED. Thank you.
Thank you so much, Doctor, for being on time. Questions posted in a QA session, so please, the faculties find time to answer those questions also.